Basics of Medical Biochemistry. First edition, 2023. Chapter 28. Biochemical Examination of Cerebrospinal Fluid. By Professor Dr. Muhammad Jawad. MBBS, Tau, M. Philosophy, Ph.D., Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau Medical College-PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. Chapter 28. Biochemical Examination of Cerebrospinal Fluid. 28.1 Introduction. Cerebrospinal fluid, CSF, is a clear, transparent, and colorless watery fluid of the central nervous system. It is contained in the cerebral ventricles, spinal canal, and subarachnoid spaces. CSF is regarded as a selective ultrafiltrate of plasma. It is largely formed by the choroid plexus of the lateral ventricle and the remainder in the third and fourth ventricles. A small amount of the CSF is also synthesized by the ependymal cells lining the ventricles and other brain capillaries. The total volume of CSF is about 90 to 150 ml, of which on average 25 ml is ventricular. About 110 to 120 ml in the subarachnoid space, of which 75 to 80 ml in the spinal part and 25 to 30 ml in the cranial part. Evidence suggests that the daily secretion is about 500 to 700 ml, implying a fairly rapid turnover. CSF differs markedly from protein-free plasma. Certain constituents are present in higher concentrations and others in lower concentrations than in plasma. CSF is analyzed for diagnosis of disturbances of the central nervous system, CNS. Because CSF is continuously reabsorbed from subarachnoid space into the blood, so if absorption is impaired, CSF volume is increased, which causes an increase in intracranial pressure. 28.2 Functions of CSF. 1. It acts as a fluid cushion to protect, buoyancy, the brain and spinal cord from mechanical injury caused by any sudden movement of the body. 2. To carry nutrients to the brain and spinal cord and remove waste substances of metabolism. 3. To maintain constant pressure inside the head and around the spinal cord. 4. It is the pathway whereby hypothalamus releasing factors are transported to the cells of the median eminence. 5. It maintains CNS ionic homeostasis. 28.3 Clinical indications for CSF examination. CSF analysis is particularly useful in various acute neurological conditions and helps in rapid diagnosis of the conditions and to initiate therapeutic measures. A wide range of disorders can produce changes in CSF composition. These include the following. 1. Infections. Infections of CNS are divided into two groups. I. Those affecting the brain, encephalitis. 2. Those affecting the spinal cord, myelitis. Many different infective agents are involved in these infections. 2. Degenerative disorders. The most important condition in which CSF examination is helpful is multiple sclerosis, characterized by patches of demyelination, occurring throughout the central nervous system. 3. Tumors. Primary neoplasms of the nervous system including benign meningioma and malignant glioma. Secondary deposits arising from carcinoma elsewhere in the body may involve the brain or spinal cord directly or may infiltrate the meninges. 4. Vascular disorder, involves either rupture of a vessel or its obstruction by thrombosis. The blood may often enter the lateral ventricle and then into the CSF. 5. Trauma. Head injury may result in bleeding directly into the CSF. Some bleeding into CSF occurs during neurosurgical operations. To a minor degree, this may happen if a vein is damaged during a lumbar puncture. 6. Therapeutic purpose. Administration of various drugs in CSF such as antibiotics, anesthetics and anti-cancer remedies. Extreme caution is required while collecting CSF in raised intracranial pressure. Table 28.1 Characteristic features and composition of normal cerebrospinal fluid. Color. Colorless. Albumin, Mg/Dl. 10 to 35. Appearance: crystal clear and transparent. Sodium, milliequivalent/L. 135 to 160. Volume, ml. Adults, 90 to 150. Children, 60-100. Potassium, milliequivalent/L. 2.6-3.0. Pressure, mmH2O. Adult, 90 to 180. Children, 10-100. Calcium, milliequivalent/L. 2.0 to 2.8. Total cell count: essentially no cells. Magnesium, milliequivalent/L. 2.4-3.0. Osmolality, mosm/kg. 280 to 300. Urea, mg/dl. 6.0 to 16. pH, lumbar. 7.28-7.32. Creatinine, mg/dl. 0.6 to 1.2. Specific gravity: 1.006-1.007. Lactate, mol/L. 1-3. Glucose, mg/dl. 45 to 80. Cholesterol, mg/dl. 0.2 to 0.6. Protein, mg/dl. 20-40. Ammonia, μg/dl. 1035. Chloride, milliequivalent/L. 120 to 130. Bilirubin, nil. Contraindications: the collection of CSF is contraindicated under the following conditions. 1. Severe shock. 2. Markedly increased intracranial pressure. 3. Suspected epidural infection. 4. Local sepsis at the site of lumbar puncture. 5. Severe psychiatric or neurotic problems and lack of patient cooperation. 6. Chronic back pain. 7. Low blood pressure and uncontrolled bleeding diathesis. 8. Anatomic malformations and scarring or previous spinal surgery at the site. 28.4 Methods of CSF collection and preservation. CSF can be collected from 3 sites: ventricular puncture, cisternal puncture, and lumbar puncture. Lumbar puncture: a lumbar puncture, spinal tap, is the most common means of CSF collection. Place the patient in a side-lying position with the head flexed onto the chest and knees drawn up. Select the puncture site, usually between 3rd and 4th lumbar vertebrae. Sterilize the site thoroughly. Inject a local anesthetic into the dermis around the selected puncture site. A spinal needle is slowly inserted in the midline between the spines of the vertebrae until it enters the subarachnoid space. The patient is then helped to straighten his back to relieve abdominal compression. Remove the stylet with the needle remaining in the subarachnoid space and record the pressure using a pressure manometer. Generally, up to 6 or 7 ml can be taken from an adult, when pressure is normal, 90 to 150 mm H2O. After collection, the CSF sample is usually separated into 3 numbered aliquots. 1 few drops for bacterial culture. 2 ml for cell counts and qualitative tests for protein. 3 greater part for biochemical tests. In certain cases, tube 4 is also prepared for special tests like cryptococcal antigens, venereal disease research laboratory, VDRL, protein electrophoresis and other immunological studies. If the measurement of glucose is indicated, 0.5 ml of CSF is collected in a tube containing sodium fluoride to prevent glycolysis. Complications of lumbar puncture. Post-lumbar puncture headache. Introduction of infection in the spinal canal. Formation of subdural hematoma. Failure to obtain CSF, dry tap. Herniation of brain. Formation of subarachnoid epidermal cyst. 28.5 Physical examination of CSF. Normal CSF is crystal clear, colorless, and gives no coagulum on standing if kept sterile. In pathological conditions, abnormalities in appearance may arise concerning color, turbidity, and the presence of a coagulum. 1. Color. The presence of blood is the main cause of abnormal color. Normally, no red blood cells should be present. Alteration in color may appear as a result of trauma while obtaining the fluid or due to subarachnoid hemorrhage. In the later type, the blood is more homogeneously mixed with the fluid. Furthermore, hemolysis often occurs and the hemoglobin liberated is converted to bilirubin, so that within a day after such a hemorrhage, the supernatant fluid obtained on centrifugation becomes yellow-colored, i.e. xanthochromic. The main causes of the xanthochromic color of CSF are subarachnoid and intracerebral hemorrhage, traumatic tap, jaundice, elevated protein level, greater than 150 mg/dl, premature infants, with immature blood CSF barrier and elevated bilirubin, hyperkeratinemia and meningeal malignant melanoma. 2. Thick viscous CSF. It is seen in severe meningitis, cryptococcal meningitis, and metastatic mucinous adenocarcinoma. 3. Turbidity. In normal CSF, there are only 0-4/L lymphocytes. In diseased state, the number of lymphocytes may increase. In viral or tuberculous meningitis, CSF appears to be turbid when the polymorphs count reaches 400-500/L. 4. Coagulation. Cobweb. Normal CSF does not clot. Clot formation is due to the presence of fibrinogen, which gets converted to fibrin to produce the clot. Fibrinogen is absent in normal CSF but increases when the blood-brain barrier is disturbed and there is a considerable increase in protein. The characteristics of the clot indicate the type of disorder. Example: the delicate fine clot is formed in tuberculous meningitis, while a large clot is formed in purulent meningitis. 5. CSF pressure. It is position dependent, horizontal or vertical. In adults, it is 90 to 180 mm H2O, but in children 8 years, it is 10-100 mm H2O. It is increased in intracranial tumors, abscesses, meningitis, congestive heart failure, subarachnoid hemorrhage, cerebral edema, and conditions inhibiting CSF absorption. CSF pressure is decreased in circulatory collapse, severe dehydration, hyperosmolality, leakage of spinal fluid and spinal subarachnoid block. 28.6 Routine biochemical examination of CSF. The biochemical examination includes the measurement of various constituents of CSF. Total proteins, glucose, and chloride are the most important constituents for diagnostic purposes. Usually, only these three are measured. The remaining constituents are measured very rarely in certain special conditions. 1. Measurement of proteins. CSF proteins may be measured by turbidimetric or colorimetric methods. In turbidimetric methods, CSF proteins are made to react with a dilute solution of protein precipitants, example 3% trichloroacetic acid or 3% sulfosalicylic acid, in 7% sodium sulfate. The turbidity produced is compared in a colorimeter with that produced by the standard protein solution. Among colorimetric methods, the Biuret method is used most commonly. The normal range of CSF proteins is 20-40 mg/dl. It is 80% plasma-derived while 20% is due to intrathecal synthesis. Plasma proteins do not cross the blood-brain barrier easily. The protein concentration is greatly elevated in pyogenic meningitis and tubercular meningitis, the rise being relatively greater in the former. A slight elevation may occur in cerebral thrombosis, encephalitis and viral meningitis. CSF proteins are also raised in Guillain-Barré syndrome and collagen diseases due to increased intrathecal immunologic synthesis. Decreased CSF proteins occur in leakage of CSF in trauma, intracranial hypertension, hyperthyroidism and young children of 6 months to 2 years of age. Albumin and IgG measurements. Because albumin is produced solely in the liver, its presence in CSF must occur through blood-brain barrier crossing. IgG, however, can arise by local synthesis from plasma cells within the CSF. The measurement of albumin in both serum and CSF is then used to determine the source of the IgG. To determine the integrity of the blood-brain barrier, a CSF/serum albumin index is calculated as follows. CSF albumin, mg/dl. Serum albumin, mg/dl. This index can then be used to calculate the IgG index to determine CNS synthesis of IgG, and to aid the diagnosis of demyelinating diseases, such as multiple sclerosis, MS, and subacute sclerosing panencephalitis, SSPE. CSF IgG/serum IgG. CSF albumin/serum albumin. Increased CSF IgG, without concomitant CSF albumin increase, suggests local production as in MS or SSPE. 2. Measurement of glucose. Glucose in CSF can be estimated by the glucose oxidase peroxidase method. The normal range of CSF glucose is 45-80 mg/dl. CSF glucose decreases in pyogenic or tubercular meningitis. The decline is smaller in tubercular meningitis, in which levels between 10 and 40 mg/dl are commonly found. In pyogenic meningitis, the decrease is drastic and sometimes glucose completely disappears from CSF. CSF glucose may be slightly increased in encephalitis, brain abscess, and brain tumors. A decrease in CSF glucose may be seen in hypoglycemia and an increase in hyperglycemia in proportion to the changes in blood glucose, as CSF glucose is generally 40 to 80%, on average 2/3, of blood glucose. CSF glucose remains normal in viral meningitis. CSF glucose levels normalize before protein level and cell counts during recovery from meningitis, making it a valuable parameter in assessing the response to the treatment. 3. Measurement of chloride. Chloride is generally measured by titrometric methods. One very commonly used simple method is the Whitehorn-Volhard method. This simple method is based on the direct titration of chloride with standard silver nitrate using potassium chromate as an indicator. The normal range of CSF chloride is 120 to 130 milliequivalent/L or 700 to 760 mg of NaCl/Dl. CSF chloride level helps in differentiating between pyogenic and tubercular meningitis. The level is decreased in both conditions, but the decrease is more marked in tubercular meningitis. In other neurological diseases, the CSF chloride remains normal. A change in serum chloride level may produce a similar change in CSF chloride level, though not of the same degree. CSF chloride is increased in hyperchloremic acidosis in chronic renal failure. Table 28.2 Abnormal findings of CSF in some pathological conditions. Parameter. Reference range. Bacterial meningitis. Pyogenic. Tuberculous meningitis. Viral meningitis. Appearance. Clear and transparent. Often turbid and viscous. Often fibrin web, cobweb. Usually clear. Pressure. Increased. Increased. Normal to elevated. Predominant cells. Polymorphs. Mononuclear, lymphocytes. Mononuclear. Lymphocytes. WBC count/L. 10-2000. Elevated, but 500. 100. Microbial culture. Positive. Positive. Yield is high in early stages. Positive. Yield is high in early stages. Protein. 20-40 mg/dl. Elevated. Greatly elevated. Normal to mild elevation. Glucose, 45-80 mg/dl. 40. Low. Normal to mild less. Chloride, 120 to 130 milliequivalent/L. Decreased. Decreased. Normal or decreased. 28.7 Other biochemical investigations of CSF. 1. Tumor markers. Several biochemical substances can be detected in various cancers. Carcinoembryonic antigen, CEA, is raised in metastatic carcinoma of the breast, lung, and bowel. Gamma-aminobutyric acid, GABA, is decreased in Huntington's disease. Muramidase is increased in myeloid and monocytic leukemia. 2 enzymes. Normal CSF is not permeable to serum enzymes. The presence of certain enzymes suggests respective pathology. AST is raised in large brain infarcts. Lactate dehydrogenase is increased in cerebrovascular accidents, CNS tumors, and meningitis. Creatine kinase, CSF-CKBB, levels are indicative of neurologic injury. Adenosine deaminase indicates meningitis. 3. Lactate. Estimation of lactate in CSF is important to differentiate between bacterial and viral meningitis. It is concluded that CSF lactate has high sensitivity and specificity in differentiating bacterial from viral meningitis. While at a cutoff value of 3 mol/L, CSF lactate has high diagnostic accuracy for bacterial meningitis. Mean levels in viral meningitis remain essentially below 2 mol/L. Summary. Cerebrospinal fluid, CSF, is a clear, transparent, and colorless watery fluid of the central nervous system. The total volume of CSF is about 90 to 150 ml and daily secretion is about 500 to 700 ml. CSF is analyzed for diagnosis of disturbances of the central nervous system, CNS. The main function of the CSF is to reduce the buoyancy of the brain. It also supplies nutrients as well as helps in the removal of waste products. CSF can be a route for the administration of various drugs in CSF such as antibiotics, anesthetics and anti-cancer remedies. CSF can be collected from 3 sites: ventricular puncture, cisternal puncture, and lumbar puncture. CSF becomes thick and viscous in severe meningitis, cryptococcal meningitis, and metastatic mucinous adenocarcinoma. The main causes of the xanthochromic color of CSF are subarachnoid and intracerebral hemorrhage, traumatic tap, jaundice, elevated protein level, premature infants, hyperkeratinemia and meningeal malignant melanoma. In viral or tuberculous meningitis, CSF appears to be turbid when the polymorphs count reaches 400-500/L. In CSF, a delicate fine clot is formed in tuberculous meningitis, while a large clot is formed in purulent meningitis. In adults, CSF pressure is 90 to 180 mm H2O, but in children 8 years, it is 10-100 mm H2O. CSF pressure is increased in intracranial tumors, abscesses, meningitis, congestive heart failure, subarachnoid hemorrhage, cerebral edema, and conditions inhibiting CSF absorption. The protein concentration of CSF is greatly elevated in pyogenic meningitis, tubercular meningitis, and also raised in Guillain-Barré syndrome and collagen diseases. CSF glucose is decreased in pyogenic or tubercular meningitis. CSF glucose may be slightly increased in encephalitis, brain abscess, and brain tumors. CSF chloride level helps in differentiating between pyogenic and tubercular meningitis. The level is decreased in both conditions, but the decrease is more marked in tubercular meningitis. Estimation of lactate in CSF is important to differentiate between bacterial and viral meningitis. References. Exercise questions. MCQ 1. A lab received a sample of CSF for biochemical analysis of a 60-year-old man suffering from some neurological disorder. What would be the expected level of glucose in the CSF of this patient, if his blood glucose level is 210 mg/dl, 35 mg/dl, 70 mg/dl, 105 mg/dl, 140 mg/dl, 175 mg/dl. MCQ 2. A patient is admitted after a head injury and sinks rapidly into a coma. An MRI scan indicates an extradural hemorrhage. Which of the following is the site for the accumulation of extravasated blood? Arachnoid and pia mater. Dura mater and arachnoid. Pia mater and brain surface. Skull bones and dura mater. MCQ 3. Which of the following findings of cerebrospinal fluid analysis is abnormal? Glucose level 50% of the plasma glucose level. Specific gravity 1.005 and protein level less than 0.5 g/L. A cell concentration of 0 to 5 cells/L. No bilirubin. MCQ 4. Which of the following results of CSF analysis suggests fungal meningitis? Elevated neutrophil count, raised protein, and low glucose. Elevated glucose level and raised pressure. Elevated protein level and raised pressure. Elevated protein, slightly elevated lymphocytes and normal glucose. Moderately elevated lymphocytes, raised protein, and low glucose. MCQ 5. Which of the following CSF abnormalities indicates multiple sclerosis? The appearance of cobweb clots on overnight standing. CSF IgG index expresses a ratio of IgG to albumin in CSF divided by the same ratio in serum. CSF protein concentration is more than 100 mg/dl. The number of oligoclonal bands increases with time. Oligoclonal bands may be absent at the onset of multiple sclerosis. Please write answers in the comments or contact drmjot@yahoo.com. End of chapter 28. Thank you.